So what we'll do is we'll hand it over to Brian. He'll go through sort of what we're doing with this one specific project called cSWO. It's one of the cornerstones of what we're doing in our strategy. Glenn will go through the project itself and describe the cSWO project itself. And then I'll follow up with what we're doing with a variety of our projects in the LHIN, our strategy, and then some of the governance challenges that we're facing and what we're proposing with some governance reform that's happening in our region. Okay, so Brian.
So let me start at the beginning. cSWO is one of 3 projects across Ontario, all funded by EL Ontario, to create an infrastructure in which to build regional and run regional healthcare applications. So there are 3 of them. They've divided the province into 3. We're calling them clusters because region and other words get used other ways, so we decided to call them clusters. So the Southwest is in fact the 4 LHINs in Southwestern Ontario. So that's Erie St. Clair, Southwest, Waterloo Wellington, and Hamilton, Niagara, Haldimand, and Brant. I worked really hard to remember that. There is what's called we're called the cSWO for Connecting Southwestern Ontario. There is a project that's ahead of us but with the same mandate called cGTA for the GTA area. It has I think there's 6 of the LHINs in there and I can't remember them all, but basically they're the ones around the Greater Toronto area. The one that probably people would be surprised at is it's including Muskoka. And one of the reasons for that is Muskoka is one of the smaller LHINs. It only has community hospitals, so in fact they get their regional support from a large academic tertiary care tends to come from Toronto hospitals like Sunnybrook. So there's an obvious connection there. The third one is for Northeastern Ontario. It's anchored really at Champlain or in Ottawa, and it takes in also the Northeast and Northwest LHIN. So it is the largest geographic area but the smallest population in total. So what EL Ontario asked was they asked 3 of the large academic hospitals to basically sponsor these projects. And so in Southwestern Ontario, they approached Bonnie Adamson and she accepted on behalf of the LHSC as the sponsoring organization. So she then turned to me and said, "It's now your project." So that's how I ended up in this role. And I think partially because the connection, because I have a regional mandate as well, and so and been advocating that we need to take more regional approaches to things. It's the University Health Network for the GTA project, and it's the Ottawa Hospital for the Northeast, and so it's a 3 projects. So the mandates are the same, slight differences in the strategies and directions that they're taking. What was really important to me and Bonnie as we talked to them about this was that this was not to be an LHSC project. This needed to be a project of a partnership with the 4 LHINs to deliver solutions that in fact were going to help healthcare providers across all 4 LHINs. So this was not, and so it's very important to me, this project is not to make life better for the hospitals, although there are benefits to the hospitals. It is really driving out, and so you'll see as Glenn presents, is really looking at how can we be practical about really supporting from primary care physicians, whether they're community physicians, whether they're family care or specialists in the communities, through community healthcare providers, right up to and including the hospitals. But the idea is to really how do we connect all of them so that we're able to share the right kind of data and help everybody improve the care and the connections across the care. So that's really important as we looked across the Southwest. And I know that's really come home to me in my own role is the fact that there are 19 hospital corporations with 30 some odd sites and other things out there. So I am very aware of them there. And we've also, for example, been advocates of the primary care network and certainly got lots of good feedback from the primary care network about the importance of us having a primary care focus to this project. So this is a bit different. So I'm stressing this because people tend to look upon, well, it's the big hospitals running these projects, and that's exactly. We see ourselves as using that ability to in fact support how the care is delivered across the entire festival. So turn over to Glenn, who's the executive lead.
Thanks, Brian. Good afternoon, and Michael, thanks for the lunch. That hit the spot.
Thank the board, it's not me.
A presentation was sent out in advance. I'm not going to go through the entire presentation slide by slide. And furthermore, I've added a couple of graphics that we can talk about. I'd like this to be, given it's an education session, as interactive as possible. If there's anything you want to explore, don't hesitate. Between the three of us, we hope to have the answer, and if not, we're not ashamed of saying we don't know, but we'll figure it out.
Sorry, can I notice the clicker right there on the table? Move the head, the black one?
To be honest with you, I'm in a bit of a strange role because I personally am not very comfortable with technology. Okay, set the mood. This is your typical primary care practice. Stack of unopened mail, unsorted results, printer with results from one lab, that's how they send their lab results, prescription refill requests on fax machine right underneath the joke of the day. The phone's about to ring with staff results. Courier just dropped off more envelopes. Web portal from one hospital to access hospital data. And where's the x-ray? I know I had it yesterday. Interestingly enough, 10 years, 15 years ago, the discussion around this kind of scenario was everything's paper. Paper files in the physician office, paper records at the hospital, everything's moved around by paper. And you have a slight chance of getting access to a patient's information if you know it's there and it exists. You can request it. Chances are you didn't know, and when you did get paper data, it was only a partial record for that individual. If there were other meds prescribed for a patient at an emergency department or at an after-hours clinic or by consulting others, you had no idea. So at best, when you go present at any point in care, even in the paper world, it was only a partial view of the health information that's relevant to your care. Big push went on to, we need electronic health records. Hospitals, big strides early on in hospital information systems, capturing data, using that data on the floor, moving now right to the point of care, physician order entry. Other sectors have lagged, but even now today, we have probably 75% of our primary care physicians in Ontario with some implementation of electronic health records. This scenario here is a scenario where every one of these data providers has electronic health records. And they still move it around by phone, by fax, by mail, they print out paper, and you still have no better idea today on who's got information about Sally and who doesn't, and complete. Different challenge, but fundamentally the same. And this is what Connecting South West Ontario is all about, is empowering healthcare providers to share their information with other healthcare providers in the right clinical context, with the right patient consent, with the right privacy security in place, but in a way that is efficient, is effective, is timely, and is comprehensive. A partial health record with missing information is more dangerous than not having one at all, like many physicians talk about. We're working within the provincial context. We heard from Brian for a bit, so I'll just touch on it. Give an overview of our project. Our project is one of a broader e-health strategy that is being built out at the cluster or regional level. So there's an emerging governance being put in place by the LHIN CEOs. You can't be accountable for the health system and not be accountable for e-health. That's the theme there. And then discussion. We've talked about the challenge. So the objective for eHealth Ontario is by 2015, an integrated electronic health record for all Ontarians spanning the continuum of care, which is accessible in a timely, secure fashion at any point of care. The province has been trying to do this. At least I've been around this game 15 years and have been very unsuccessful. So what we're seeing in their current approach is recognizing some of their past struggles. This is somewhat abstract, but it's not feasible for every clinician who has electronic data to share it with every other clinician on a point-to-point, one-to-one. If a hospital has to get electronic downloads from every physician that they deal with, that's thousands of points of contact they have to figure out and make sure they're working, and point-to-point doesn't work. So the standard architecture in an information sharing environment with many complex players fragmented is a hub system. Everybody puts it through a hub, and then it goes out to where it needs. You'll hear three components to these hubs, and I'm not going to dwell on them a lot, but that's the technology, but it is in the presentation. One core element of a hub is the health integration access layer. And that's nothing but the Canada Post in the electronic world. Understands postal codes, knows what stamps look like, can run it through the reader. So it's the ability to move data from one source to another destination and have all the smarts to do that. A second is the clinical data repository or repositories. For large information systems, such as those that hospitals have, they don't mind every time somebody needs information providing direct access to their hospital information systems. They have the capacity, they have the scale. Smaller healthcare providers, such as primary care providers, with their electronic medical records on a PC under their desk, cannot provide the data feeds and data streams. So the strategy there is to collect data into a hub and then make it available from this collection point, almost like a post office box, so that they know I only have to send a piece of data out once, and thousands of potential providers can access that by going to that repository that I created. And the third piece of these cornerstone hubs is the clinical viewer. Not all information needs to get moved from system to system. In many cases, a physician only wants a small subset incorporated into their electronic health record, but they want to scan it all and see it, and then they're not interested anymore. So the clinical viewer is the primary initial vehicle for accessing data across the healthcare continuum. So those are the three fundamental elements that go into a hub that allow that flow of information between the provider systems. That's the architecture there. We've tried to do it province-wide. Just too big, too complex, too many players. So Brian said they grouped us into three clusters. And it's not just arbitrary. If you look at tertiary referral centers and patient flow patterns, these clusters make some sense. And the province itself is a data collection point. They want to share their data. And they also, for system management purposes, want data back from the health sector. So they will be a fourth hub. So conceptually it's going to look like something like this. A information sharing network or an integrated electronic health record, South West, CGTA, and Northeast. Makes life a lot simpler for the province. If they want to push their information out, or if they want to collect information back, they've only got 3 points of integration. I think this is the key. Each cluster can develop a blueprint or a roadmap and an implementation plan that makes sense for that part of the province. It will maximize opportunities to leverage existing assets to rapidly attain clinical and health system management benefits. We're not starting at square zero. Granted, different parts of the province have moved further ahead in the ability to share information than other parts of the province. And we know that building systems and solutions at the provincial scale and then deploying them is a multi-year prospect. We don't have time. The need for sharing information is urgent. So our cluster blueprints, and Southwest in particular, will leverage investments we've made to date for rapid information sharing for clinical benefit. And also the healthcare system priorities across the province aren't necessarily the same. That's why LHINs were created, to emphasize on local priorities. So as we deploy our electronic health record and information sharing services, in our cluster we have the ability to support our access to care strategies, our aging at home strategies, our ALC day strategies, and how we deploy it and where we put the initial emphasis. And finally, divide and conquer is a nice strategy. CGTA, fine. When it comes to the focus, you work from acute care out to primary care. Our priority is primary care data across the continuum, and when we've got it figured out, we can mix and match and work in parallel. So each cluster is to plan, establish, and deploy an integrated electronic health record associated services, aligned with eHealth Ontario's blueprint standards, and make information accessible across the continuum of care.
I just stop for a second. This is really important. This is actually of significant importance to LHIN and myself. Is we are adopting eHealth Ontario's provincial standards for how this puts together. We are not inventing them ourselves. We're sticking to the standards that will allow interoperability in the future. So that's really critical to us. So that we're structured will be exactly the same way as everybody else is structured, following exactly the same standards, which allows much more of a plug-and-play kind of approach to share applications in the future than to have three customized, completely separate and independent solutions running across the province.
I'm feeling better about that because I was a bit worried when you said one cluster, you're developing in 3 different clusters.
Oh, yeah.
Because children's care runs province, it doesn't run regionally. We have children that are on the other side of the province, those kinds of things. So I worry about some of those initial programs where access does matter across the other side of the province and that kind of thing.
And what's critical here is that the technology underneath the hood, basically, that will be invisible to people, will be highly standardized. It's how we use it is where we can get the flexibility in terms of meeting the needs of the region.
So eventually the hubs will be able to access, you'll be able to access any one of the hubs.
Exactly. Well, if you take LHSC's place, we get patients from all over the province. We get them down to North Thunder Bay. You want those references coming down electronically. Right now they come by fax.
All 4 of these nodes will be able to communicate and exchange information seamlessly.
I know nothing about it, but I could never understand how the banks are able to do an information system globally. I was in the insurance business. We took 3 or 4 runs at it in my 17 years. Yeah, as far as I know, they still can. And now in health, we're taking lots of runs at it. So hopefully this is good.
Well, part of the challenge is that we've got so many different organizations. We're not all one organization with one set of rules to follow, and that's been part of the challenge of making this work. And I think we've taken a pretty good hard look at this. And as far as I'm concerned, because I look at this from a business or care delivery perspective rather than from a technology perspective, this is the best approach I've seen in us to be able to move forward in the problem.
This is the objective. Within the scope, there's of course technology, and I talked about these 3 pieces of how to make this electronic health record hub work. But at the end of the day, this is probably the least significant piece. How do we govern an integrated information solution and health sharing network? Who's responsible for what data? Where do the accountabilities lie for ensuring that there's a complete view of a patient's information? How do we operate and deliver this kind of service? We have a hard enough time getting healthcare providers to collaborate on shared healthcare programs, and we're talking about building a shared program that spans 4 LHINs. What about supporting the thousands and thousands of potential healthcare users? There's nothing of this scale in healthcare from an IT perspective at this point in time, and sustainable funding for this kind of activity and service at a time when we know we're headed into a real financial crunch in healthcare. You don't just throw up a system and it works like the internet. How do you register healthcare providers and make sure they're using it appropriately, and when they're not allowed to use it, their passwords are shut off, and that providers are only allowed to access those functionality and data that's aligned with the role that they're playing? And how do we manage a patient's consent? Well, consent for this group of providers to access my data. This group can only access this amount, and ensure that those rules are obeyed. The whole information management, privacy, auditing and compliance, introducing changes in the way the health system works as a result of this, and getting our healthcare providers not only to contribute as data sources, but then to adopt the services as data consumers. I think these are by far the greater challenges than what technology we use and can technology get the job done.
Can I just ask a question around our rural areas? We have urban centers here, and certainly our rural areas are quite large and significant. A lot of dial-up, and we're hearing a lot of complaints even from back on the eHealth line where the pages are way too complicated. One page takes a half an hour, like that's not access. Is there another structure that's involved in that infrastructure around getting dial-up off the ground and getting it into high speed? Is there someone else you're working with collectively? Because as many things as you put in place, if we don't solve that problem, it's not helpful.
Clearly, network capacity is a challenge. And what we will do is this project, by liberating the information and putting all of the soft services in place to allow that access to happen, we will be putting a spotlight on network deficiencies, and we'll be working with those parts of the organizations, part of the ministry in Health Ontario that are responsible for that, to remedy that, or we don't have a solution. We ourselves will not be responsible for network configuration, network acquisition, network build-out, but we will certainly be the supporting business driver to make sure we get adequate service. It'll no longer be the healthcare provider on their own saying my network's not giving me the performance. It'll be the collective cluster saying our system's not working because we don't have adequate capacity.
But you've hit a point of exactly why we thought we needed to start at primary care and recognize the rural environments, which is not a rural CGTA, for example, is even thinking about it, was exactly that point, that we've got to get the critical data out in a way that's usable to people. Because it drives me crazy. I got a high-speed connection to my house, and they still take longer and longer because people keep building fancier and fancier. In fact, we may have to have different versions of things, some that are very simple, very, very low data use. And that's the kind of things that we want to get out of the consultations with people, is to understand what really needs to be in place. And it doesn't necessarily mean fancy. It means what do we really need to put in place to deliver, because that's really evident to me is that we've got to get it to, if you think about where every primary care provider is, just in our LHIN alone, that's exactly what we've got to solve. We can't, this is not to solve how do we get data to people in London. This has got to solve the problem of how do we get the right healthcare data to every healthcare provider. I mean, it's one of the things I talk about in Toronto, and I get blank stares when the point I make to people is that a majority of our communities are too small to have a Tim Hortons franchise.
But it's absolutely true.
But it's true. It's absolutely true.
We heard this at the physician engagement, which is why I bring it up, because the
Exactly.
concern was, if I'm out on the peninsula and I'm up where Barbara is, and we're up in the Tobermory area,
Exactly.
I'm a physician up there, I need to access this stuff. It's
Exactly.
more important that I access it because I'm in a remote area and I don't have access to everything you do in a clustered area. So for this goal, and it's admirable, in a couple of years, I don't understand how we're going to do that if that infrastructure piece isn't in place. So you've probably got more creative solutions than I do, but certainly the physicians were worried about it.
Yes, and it's going to, and there's no question in my mind that network capacity or lack thereof in parts of the rural areas is going to limit how sophisticated or what we can do for them until that gets fixed. But I think what we're trying to do is understand what those needs are, flag them, but also make sure that we're recognizing that certain things need to be put in place, like simpler applications or lower data demand kind of applications or viewers that are specifically designed to help those people, at least to make it more tolerable for them as we go forward.
Thanks.
Absolutely.
Okay, Brian mentioned that eHealth Ontario is going to be setting the standards. CGDA spent a number of years going through a planning cycle and now moving through implementation. They're going to establish their cornerstone solutions. Their objective by late 2013 is to have 12 hospitals connected and the Ontario Laboratory Information System connected, and that data available to 700 physicians. And we're building on the work of CGTA. We've launched an accelerated planning. These kind of objectives are tied to what assets you have to leverage today. And if you have a fairly complex but greenfield environment, then you have to build these things and slowly roll them out. I think you'll find that when I go through Connecting Southwestern Ontario, we are rich in assets from work that's been done over the last 5 years in our 4 LHINs, that we can have a more ambitious objective with respect to populating a health record and making it widely available across the continuum of care. Patient benefits, health system benefits, and one of the benefits that's hard to articulate is the healthcare provider benefits because it's somehow spread between the two. But in my experience, particularly in working with physicians, primary care physicians, the lack of ability to get timely access to information, it really is painful and hurts the patient-provider relationship because the patient expects in this day and age to be there. When a patient presents and says, have you got my cancer test results? And the physician says, no, I knew we booked the appointment, but they haven't come yet, and I can't get them. It's not a good quality of life, personally and professionally. And I think that's an area of impact that difficult to capture, but very significant. And I go back to, would you like to live in that kind of office that we saw in the first slide? Okay, here we go, connecting South West Ontario. Similar objective as the provincial strategy. We're in our planning phase. We've done a scan through our initial proposal to what would our priorities be. And lo and behold, we are well positioned to deliver a first-generation integrated electronic health record for 4 million Ontarians that will span a significant portion of the continuum of care. Why? Because we have things we've done and we can leverage, not just technology, but we know how to share information among providers. We know what data sharing agreements are. We know what privacy policies are. We know how to certify community-based providers to allow them access to institutional data. We have a diagnostic imaging data repository that all hospitals across these 4 LHINs feed. We have a Clinical Connect viewer which accesses hospital and CCAC data, allows physicians to download it in their EMR, and allows view access across the continuum of care. It connects all of the hospitals, all of the CCACs of Hamilton, Niagara, Wellington, Wellington, LHIN. We have an integrated assessment repository, community mental health and addictions, long-term care, community support services. Those sectors were fraught with an individual having to get assessed everywhere they went and multiple times, and this data wasn't getting shared. And it certainly wasn't getting back to the primary care team. We now have implemented standard assessment tools, and those standard assessments go into a shared repository, and as more and more of our providers produce that, that's available across the continuum of care. So we've streamlined and made more effective the assessment processes. Spire, the ability for hospitals to send out their data to physicians when a physician has a patient present an episode, and physicians can incorporate that directly in Southwest Ontario. How many physicians have you got using that service across your 3 nodes?
500?
500. So if you look at these things, say, wow, wait a minute. There's pieces to the puzzle here that if we work with properly, we can, and then let's focus our implementation of the provincial standard cornerstone solutions in the first instance on filling those key gaps. And where we have a key gap is in the area of access to primary care and chronic disease data, and also the Ontario community lab data. So if we're going to emphasize new development with the provincial standard cornerstone, that's the place to put it. Furthermore, it complements what Toronto's doing, who's looking at hospital out. Well, we've got that covered. Why don't we look primary care out? And really focus on the needs of community-based physicians and other healthcare organizations, because they are the have-nots. So if we said, okay, if that's sort of our priority, now we can focus our planning exercise. We've identified 3 streams which address the priorities, and it's that balance. I'm going to take 2 minutes. One objective is to have a standardized, architected, province-wide e-health system. So it's an architectural and standards objective. The other is a clinical and access to information standard. Get the data in the hands of the clinicians when they need it, where they need it. The two are interrelated because an architected solution allows you to achieve that clinical objective. But there's a balance. You don't necessarily have to have the initial ultimate architecture That's the standard to which you're building. Because what do they say? Perfect is the enemy of good. If you can get 60 to 70% of the way there, and then over time migrate to that ideal architecture. So what we're doing is we're all about that balance. Stream one. It's not about technology. It's about solving all of those business issues, policy issues, process issues. Doing it in a way which is practical, doing it in a way which is actually driven by the imminent need to deploy something as opposed to a conceptual exercise. And it's also leveraging work that we've done in these areas because of these other projects. Then let's go and deploy our clinical viewer cluster-wide and initially provide access to hospital data and CCAC data across the continuum of care. And then we can feed other data through that clinical viewer. And that's what Stream 3 is about. Plan for cluster-wide deployment of our clinical data repository and the health information access layer. Build on the work we've done in the community sectors around integrated assessment. Expand that scope, whether it's through the SPIRE project or the IRE, to get, finally, bring all the primary care data together, provide access to it, link to our diagnostic imaging repository in the lab system, and provide access to these via that clinical viewer. I mean, we've got these pieces, we're just assembling them and figuring out how we can roll them out and support them cluster-wide.
So Gwen, you want to pause it for a second? So bring it back home to our LHIN, because you obviously govern all the matters within our LHIN. There are initiatives that we're pursuing that are the requirements of what's deemed important for us, that will also be able to leverage these tools. So like the meeting that Kelly and you and I were in the other day, we're trying to figure out the situation around how do you create a primary care source of information that clinicians can use and the circle of care can use to better manage chronic diseases like diabetes. And that is kind of following on some of the work that was done for partnerships for health. If you remember that initiative, those of you, that goes back a few years, project planning terminated last year. How do you carry that on? And how do you use technology to help share that record? That kind of falls into bullet number 2. So, though these are regional cluster initiatives, there are benefits that can accrue directly to the LHIN specific, and these are initiatives that the office, the LHIN office, are trying to attain, focused on this particular LHIN.
Glad to hear you say that, because we heard at that last physician engagement that the NPs weren't able to access certain pieces of information as patients were being discharged, and access was an issue for some of those. They're part of a primary care team, but they were having trouble accessing it, so I'm glad you're expanding that area quite a bit. New members coming on that we didn't currently have, say, 5 years ago, and MPs would be one of them, where they're part of these bigger teams. I think it's interesting that when we're doing the physician engagements or some of those other community information sessions, we start to hear about these things and how it's not working for them.
And this is why we have an opportunity like nowhere else in the province, because independently, and in some cases in partnership, our health service providers and our LHINs have been innovating. Waterloo Wellington, for example, created 3 diabetes care networks, which were across the continuum of care: emergency department, specialist diabetes education centers, primary care, etc. We created one shared electronic health record that would be accessible to the entire care network, which was also accessible to the patient, who could then share it with whoever else they wanted to. And I mean, the benefits for that were just enormous. But could Waterloo Wellington implement something operational long-term that enabled that? No. But it clearly helped define the requirements.
Glenn, I'd like to see you build in, though, components somewhere within this rollout where you stop and pause and ask those who are accessing the information, is this working or not? And I haven't heard you talk about that. Now, I was looking for it. It's not in any of your charts within here where you stop and do that pause.
I put this here at the bottom, and it absolutely did get short shrift.
Okay.
And that's why it's here. Benefits evaluation and monitoring of what's working and what's not is a critical component.
It needs to happen more than once.
And it has to be ongoing.
Yeah.
And I'll tell you why I believe it has to be ongoing. In environments where I have seen information access enablement happen, we have no idea what that's going to do to healthcare delivery and how that's going to drive additional demand and change. In Hamilton, Niagara, Waterloo, Wellington, where primary care physicians have access to Clinical Connect, which is the cSWO data and the acute care data, they're starting to link that with other data sources they have, create new views, they have new demands. I mean, they're taking it in directions we have no idea. So it's not just what's working, what's not. It's once we have the first, I call it first generation capability, it's the health system has to tell us where they want it to go. Because at this point in time, we cannot predict. And this is, again, I think, one of the positive things about the cluster approach and us having some input into our roadmap and how that evolves is the typical big system approach is you define all your requirements up front, you architect the thing, you build it top down, and then you go into a multi-year revision cycle. I don't think that is the model of this. It has to be more iterative, innovative, and focused on clinician empowerment.
And Linda, this is of course at a large project level. You bring right down to Spire, and I'll touch on it when I do my segment. We have the University of Western Ontario conducting a review on Spire and the benefits, and then using that to measure empirically and quantitatively what accrues as benefits out of using a platform like Spire to the physician, to the patient, to the system. And in that framework, the idea would be maybe we can use that to evaluate other e-health components. So now we have a structure for determining what is the benefit, how do you measure that, and to standardize that. So that's being led by Deb Combo. She's on our e-health steering committee, and she's a professor at the university.
That's good, because I mean, we've now got a tool out there, the eHealth line, which right now is not working for better than half of our population. And I've heard it in probably 5 different community meetings that people can't access the information. Lots of information on there, but it takes, one lady said it took her overnight to download 5 pages, like that's silliness. So, you know, put the tool in place, but if you don't stop and look to see who those users are and whether they can actually do it, it's not helping us at all. We're not moving forward.
So our planning framework is going to look through those 3 streams that I think a fairly rich and robust scope of health information available from priority sources, priority data types, some available directly, some available through our clinical data repository, new and existing, but accessible through our clinical viewer out across the continuum of care. And this is just an example of what the Office of the Future across Southwest Ontario should be. I got a patient. This is what data exists in the system about them. This is where it exists. And as a clinician, I say, I want this, I want this, I want this, and this I want downloaded. And this is live for a subset. This is right now Clinical Connect in Hamilton, Niagara, Halton, and Brant for hospital and cSWO data. It's one of those things we can build on, but it's that kind of environment that we want to move towards. So this isn't conceptual. It's taking things that we know work today, solutions that we've developed, lining them up under the provincial umbrella and putting them to work. Critical success factors. Clinicians and stakeholders need to be engaged deeply throughout and ongoing. We have to have formal governance and representative governance. Brian was saying this is not an LHSC project, but it has to be a health sector project, health system project across 4 LHINs. We're headed for financial crunches. We can't jump into something like this, create the service and the demand, and then try to figure out later how it's going to be funded, particularly when our health service providers are not looking forward to significant increases. Deliver value early and incrementally. Don't try to wait for the ultimate solution. Look for practical solutions to complex issues, and we've mentioned these before, and in many cases we've already taken the first steps in some of these areas. And absolutely, this is not a technology project, but it's about establishing a new mission-critical healthcare program. We worked through the spring to get the project proposal approved and funding allocated. I think the funding allocation for the phase 2 and phase 3 was $50 million. We're now into phase 2, which is the detailed planning, engagement, and future state design. And we hope to be ready to move into implementation in March. The March is a conceptual date. We know there are significant reviews and approvals to go through. We know the budget process that happens provincially every spring and sometimes goes through the fall. But from a project perspective, our objective is to have an implementation plan that we can begin to execute in the spring. This is tough to look at, but I'm just going to touch, this is the governance structure. eHealth Ontario is the sponsor, London Health Sciences is the project delivery agent, Brian is the executive sponsor. Brian is putting in place a broad representative steering committee across all 4 LHINs, representing the majority of sectors, representing the different perspectives, technical, clinical, and system management. That steering committee is being formed and is having its first meeting next week. We have our project team. This is a group I'll talk about briefly. It's called the cSWO Strategy and Architecture Alignment Subcommittee. Yes, we have a growing number of eHealth projects in South West Ontario. Connecting South West Ontario is one of them. But when you look at an integrated eHealth system, you start with the clinical provider systems. And they're out there and they're one-off all over the place. The first thing you need to do is be able to link them and share information between them. That's cSWO. When you have that ability, you can then begin to look at eHealth services like, well, how do we best navigate the system? And how do we manage our resources and refer patients in a timely fashion? And how do providers coordinate their care delivery and the integrated care plans? So you can begin to look at health service access and integration solutions. And then you can look at patient consumer services and solutions that are layered on top of that. Working across health system management solutions, and of course, all leading to clinical care transformation. So cSWO is that bridge between the fragmented, disjointed provider clinical system world to information sharing, which is cSWO, to the high value add other solutions we can introduce into the healthcare transformation agenda. As such, we are setting an architecture and a strategy for Southwest Ontario, and hence we're implementing, within the context of cSWO first, the Strategy and Architecture Alignment Subcommittee. And when cSWO sets that, that committee will become part of the ongoing governance structure, so as other projects get initiated, the ability to build on this and lead towards an integrated system has a chance of coming to fruition, which is a segue into, this isn't just a project, but it's part of a broader whole and growing portfolio of projects, and Glenn, I'll turn that over to you to talk about.
So Mike and Jeff, how much time do we have left to bring this home?
10, 12 minutes.
10, 12? So thanks, Glenn. In the context of where we exist, there's a lot of players, right? And so you sit on a board right here in this little bubble, and we try to manage 3 networks that we break out between the north, the central, and the south of our LHIN. And so what's being described with Glenn and Brian is we're now in this cluster with 3 other LHINs, and it sits within other clusters that are grouped together, and we're all trying to figure out what the ministry is driving in terms of programs and how that aligns to eHealth. But organizations like OTN, eHealth Ontario, Cancer Care Ontario, where Brian's the regional lead for the cluster, and organizations like Canada Health Info that fund out projects that align to a national architecture. It's quite a verbal, right? I mean, how do you coordinate that? How do you make it happen? So, Ron, when you talk about the banking industry and trying to make that analogy, the problem is we got so many players here where standards are being set to align to technology. And keeping these players aligned and servicing these people in a way that is everybody agrees on has always been a challenge. especially in the province of Ontario. And it has a lot to do with the way we're structured. So we had to go through, just to bring it home a bit, I had to look at the northern roadmap for technology. So this is the Grey Bruce area. Then keep your seatbelt on, okay? Then I had to do the Huron-Perth, like what are you doing in Huron-Perth? And that was their roadmap. And then I had to go to Thames Valley and figure out what their roadmap was. And then I had to go to Infoway and figure out what their roadmap was. And then I had to go to eHealth Ontario and figure out what their roadmap is. Everybody okay? And then I had to go to Cancer Care and figure out their 4I approach to doing everything. And then I had to figure out what OTN was doing. It's pretty mind-blowing. So when you have all those different pieces going on, and we try to provide e-health solutions specific to our LHIN, so I'm trying to bring it home to our South West LHIN, we had to come up with a strategy that this board approved. And this was the strategy that the board approved back in about a year ago now, that got into sort of the different quadrants of where we want to focus and the projects that we have. That's very similar to the slide that Glenn presented, which was more of an architectural one, where he talked about you got to focus on this, and then you got to build out to some other solutions to help with navigating through the system, and then you can get to the consumer piece. Sort of strategic visual that we had here developed in the roadmap is quite complementary to the way things are going generally, but everything that was talked about earlier sits right here. And so for our LHIN, the contributing pieces that we have, that we initiated and started in our LHIN that contributes to this bigger piece, is the Spire project. And again, that was described as records from the hospital through a piece of technology to bring it right into the physician's office, so they have it right then and there. So this schematic is just intended to bring it back to our LHIN. So this is our LHIN strategy. This is our piece, and there are pieces in here that are going to contribute to this broader solution. Spire is one of them. And at some point in the future, these pieces will all have to come together, because this is not the only piece. So when you deliver e-health, message number one is e-health is not just building out the integrated healthcare record. It's moving people through the system. It's having a database, a warehouse to analyze data. What do LHIN provide? What services do they provide? What's the supply and demand of all of that? And then what's the quality and process improvement? And then we're going to add here, based on some more government reports coming out, the cost, ROI, the return on investment, because we're going to all have to measure that right down to every project's going to have to account for how are we contributing to reducing costs that the province has incurred over the past few years. So this is really going to get at saving the province, providing health technologies, and then the consumer. And the folks in our office know that we're constantly trying to push this, but as Glenn stated, we kind of have to get through this piece first, and then we can eventually start to provide solutions right in the hands of our consumers. So one of the big success stories is Spire, so Southwest Physician interface to the EMR, and this is where physicians actually can get the information from the hospital right in their electronic medical record, and you can see the adoption numbers here. So the amazing thing is our entire LHIN is connected to this. So every hospital network is connected to this, sending information to those connected that have an EMR and are on the Spire interface. So you can see all the numbers here that add up. All 3 hospitals adopted by the entire LHIN. So this is a huge asset that we're going to contribute. So when Glenn talks about we got to leverage stuff now to get to where we're going, this is already in place. Like the meds, like that other viewer that you saw, the Clinical Connect viewer, this is in place delivering value. And if you were at the physician engagement session last year, physicians were actually standing up and saying, this is like one of the best things that come out of eHealth. It was developed here in our region, started in Grey Bruce. So the big problem that we're going to have is I think governance. How are we going to start to work together? How are people going to work together? How do folks responsible for governance and initiatives in their own world start to work with the broader world? And that's going to be the biggest challenge. So the CEOs, the first point is the CEOs of the 4 LHINs have all agreed and signed off on working together from a regional perspective to drive eHealth. So at the most senior level, they're going to get coordinated to help drive and promote eHealth. So that's great, 4 LHINs working together, the leadership by 4 LHIN CEOs. So the initiatives will be driven by a variety of strategies. So as you know, as you saw in that other diagram, we've got cancer care, the ministry, other LHINs, other hospitals, other HSPs. And to basically try to coordinate that and have all these projects on the go requires leveraging capacity. Because you can appreciate if you have one group doing one thing and another group doing another thing and another group doing another thing, you're not leveraging the capacity. And we will soon become very accountable for the capacity and how much we're leveraging in terms of dollars spent on particular activities. So if we can start to effectively outsource to a group that can do privacy or another group that can do security, you should leverage those across projects, not have individuals in every separate project. So you create efficiencies and economies of scale. And then, so what's being proposed then is an oversight committee in Southwestern Ontario with the 4 LHIN CEOs, senior representation of eHealth Ontario, and the ministry, and that's at the ADM level. So the policies and programs being promoted by the ministry are directly tied to what the CEOs are trying to deliver with their organization and you as boards. Because if you can't explain it, and the policymakers can't explain, and the CEOs and those that drive the technology can't say this program is being delivered and supported by this piece of eHealth technology and make the link, it's really hard for the people in this room in our LHIN office to have to do it ourselves in isolation. So where governance is going to require leadership, and leadership is going to require change, and that's going to create some pain. This is the structure that's going to try to at least get us moving forward in a way that is all about changing governance. So this is pretty revolutionary in Ontario, because never before have CEOs of LHINs with an ADM, now we still have to get them to say, okay, we're getting a letter out to them very shortly, really drive the process. Now, this middle group here is the ones doing all the work. So this delivery council is representative of all of the LHIN stakeholders, which spans LHIN CIOs, key organizational CIOs, the project leads like Glenn, eHealth Ontario, Ministry of Health, and InfoLay, to really make sure that everything's in balance and that the ship is going in the right direction. Because right now, nobody's driving the bus, right? It's just like everybody's got a piece of it. So that delivery council is a group that's going to see that way forward. Now, every one of these projects, Southwestern Ontario, the connecting Southwestern Ontario that Glenn described, would sit here with that architectural committee here. And this piece of it is really driving a lot of what's going to get standardized through all the other projects you're hearing about. And what's important about this is that eHealth in Ontario is not just eHealth Ontario. eHealth Ontario is funding this project, but RM&R is being funded out of the ministry by one ADM. CCIM and the IAR, that integrated assessment record, is being funded by an ADM in another division. And then you've got many other projects that are going to start to come that aren't sitting in the same place in the ministry. And some of the projects are funded outside of the Ministry of Health. So, that type of complexity, you need a governance structure that keeps things organized, leverages all of the same resources to create economies of scale, and effectively create an outsourced business process unit that does a lot of the work for all these projects. And then what's very important, that hits close to home for a LHIN, are the accountability agreements. So when you get funding and you're coordinated and you're organized and you're governed, how do you sustain it? And how is that going to happen? Well, it's contemplated that. We will use our accountability agreements with our health service providers like London Health Sciences Centre to help define the role that they'll fill, as well as all of the other HSPs in our region. So somebody like London Health Sciences Centre is an example of leading this phase of a project. Doesn't feel like they're left in isolation, or the world's not saying, make it work. And they don't feel like they're left out in the cold, and pressure's taken off their shoulder. Because LHSC or any other organization leading any one of these projects will not be successful on their own. They'll be successful only if supported by the network. And that takes a different way of thinking. And LHSC is a good example of an organization that's changing that thinking. LHSC wants to be a regional player. It doesn't want to be a dominant hospital in this part of the province. It actually wants to support and share and provide its resources to help drive regional initiatives. But they can't be successful unless they're embedded in a governance structure that changes the way they can operate. In the interest of time, I'm going to leave it there, because that's the most significant takeaway in terms of you as governors to think about the whole governance idea. eHealth is a program in Ontario. We're looking at changing the way it's governed. And you as board directors of the board sit on top of this structure. That's it. Thank you.